The last thing we discussed was, are you hearing echo from my side, please? You are muted, I can't hear you. Any echo coming from my end?
No, ma.
No, okay. No. Thank you. All right. So the last thing we discussed was adjuvant analgesics. And we said these are usually complementary strategies that you would want to use for neuropathic pains and some other type of pains. So we discussed this. I showed you this picture. I said these are like the neurotransmitters that are being released in the brain when we're experiencing any painful occurrence that is not incited by an outside injury. So like the nerves are misfiring and giving pain signals even when there is no pain going on. And then we got to this slide. So this slide is just a list of some drugs that you will commonly find that they are prescribed for neuropathic pains. But primarily they have other functions. So there is the group that is called tricyclic antidepressants. Usually they will use such for continuous neuropathic pain, pain that is there 24/7 for a couple of months. Such pain, because they don't have an exogenous origin. If I have pain because I have a fracture here, I'm not confused as to the source of my pain. I know why I'm having pains. But if I am having pain and there's no external source and the pain goes on for like 6 months, after a while, I may be prone to depression because I'm wondering what is this pain that is not going and I don't know the cause. So pain that is complicated by depression or insomnia. So the person may outrightly lose sleep. So what are common drugs that are given for such? Amitriptyline is one of such drugs. Doxepin is one of such drug. Imipramine is one of such drug. Nortriptyline is one of such drug. The commonest one that you will find prescribed is amitriptyline. Amitriptyline comes as a single tablet of 25 milligrams. So sometimes we can start with half of that tablet. That's why they say starting dose is 10 to 25 milligrams. You can start with half of that tablet, which is 12.5 milligrams. If the pain is still not controlled, you go to 25 milligrams. If the pain is still not controlled, you go to 50 milligrams, and you can go as high as 150. As high as 150 milligrams is 6 tablets in a day. So that could be 2 in the morning, 2 in the afternoon, 2 at night. So it will do dual function of these neurotransmitters, these brain hormones, brain chemicals that are firing and giving abnormal pain signals. It will do the dual function of calming them. It will also do the dual function of reducing the patient's depression. It will also still do a third function of helping your patient sleep better. So that drug has multiple benefits. So another class of adjuvant analgesics that you will come across in your line of practice is anticonvulsants. You know what convulsion is, that epilepsy kind of thing. So anticonvulsants are drugs that are used for seizure disorders. But in persons who have pains that are shooting, they call them lancinating pain or lanceting pain. You know that blade that we used to cut when we have to do procedures? They're called lancets. So such pains feels like something is cutting them inside, or it feels like something is shooting inside, like you're poking them with something sharp. So for persons who have this nature of pain and it's gone on for a long time, that's why they wrote lancinating neuropathic pain. The preferred drugs for such persons usually is, come in please. My laptop is acting up. I want to change my. Can you hear me, please?
Yes, ma'am.
Okay. So what I was saying is that it's for pains that feel like you're being poked with a needle, or pains that feel like you are being cut with a blade. The common prescription will be carbamazepine, phenytoin sodium, valproate, clonazepam. All those drugs are anticonvulsants. The commonest one you will see around here is carbamazepine. You'll find it in the pharmacy. We give some patients with that kind of weird chronic pain. The starting dose usually is 200 milligrams. It comes as a single tablet of 200 milligrams. Then we titrate it up. So titrating it up, you can go to 400 milligrams, which should be 2 tablets. Could be 1 in the morning, 1 at night. If the pain is not controlled, you can go to 400, you can go to 600 milligrams, could be 1 in the morning, 2 at night. And you can go as high as 1,600 milligrams. If a single tablet is 200 milligrams, and the maximum dose your patient can take in a day is 1,600 milligrams, tell me, how many tablets would that be? If we can go as high as 1,600 milligrams, a single tablet is 200. How many tablets, how many times a day would that prescription look like?
Ma, please, can you go again, ma?
Okay, I said a single tablet is 200 milligrams. And we can go as high as 1,600 milligrams in 24 hours. So what will your look like is, if you say 2 in the morning, 2 at night, that's 800 milligrams. What possible prescription could you give to the patient?
Three. 3 in the morning. 3 in the morning, 3 in the afternoon, and 3 at night.
That would be 600 times 3. 600 times 3 is 1,800 milligrams. What else? Try again. A possible dosage could be 2 in the morning, 3 in the afternoon, 2 at night. That would be 400 in the morning, plus 600 in the afternoon, that's 1,000, plus another 600 in the evening, that's 1,006. So you'll be able to cover your 1,600 milligrams in 24 hours without shooting above that dose. Okay, so another class is oral local anesthetics. You know what local anesthetics are now? Those are drugs that numb bout pains. The same way we give lidocaine. Lidocaine is a local anesthetic, just that it's an injection. It's not so common, but a member of that class is neurolept analgesics. So that is mexiletine. It's not a common drug. You may come across it, you may not come across it, but just know that it was mentioned. Then we have the ones that are called neuroleptics. Usually they will be given for pains that are complicated by delirium. Delirium is that state of confusion, of not being oriented in time, place, and person. So the person has so much pain that it loses consciousness of time. The person has so much pain that it loses consciousness of location. The pain is so confusing that you bring the person to the hospital and tells you, actually, I'm still in my house. So those kind of pain, they're called neuroleptic pains. Or it may also be accompanied by nausea, or a refractory neuropathic pain. The refractory pain is, it comes, it goes, it comes, it goes. So it's unpredictable. And the patient is fine, then goes to work, and that severe shooting pain comes. And that ends the work for such day. So the drugs that are given for such have a bit of antipsychotic properties, like the same drug they will use for patients who are schizophrenic. Not even that they have a bit of antipsychotic properties, they are antipsychotic drugs that are given to such people. So example of such drugs are flufenazine, alloperidol, metotrimazine. Now, the two you will find there are flufenazine and alloperidol. Flufenazine many times comes as an injection. Alloperidol is one pink tiny tablet. But you would only give or bring out such as a means of adjuvant analgesic when you can see that my patient, in addition to the pain, is exhibiting what looks a bit like psychotic manifestations, or a bit like delirium, confusion, loss of consciousness. Not that the person is not awake, but the person really doesn't know self, doesn't know time, doesn't know place. Okay, so that explains a particular group of adjuvant analgesics. So the other one I'll quickly explain now is still the same one. Maybe I'll just briefly give an overview of them. There are some that are antihistamine. Antihistamine are those same drugs that you will use for catarrh. So the side effect of Piriton, what's the side effect of Piriton?
Crashes.
What's the side effect of Piriton?
Drowsiness.
Drowsiness, okay? So most antihistamine, what they do is put you to sleep. That's a possible side effect. So if your patient has this pain that histamine as an addendum, at least while the paracetamol is doing what needs to be done, perhaps the patient will now be able to sleep. So example of such is hydroxyzine. That's an antihistamine. Then we also give muscle relaxants. Muscle relaxants, especially because some of those pains are caused by muscle spasms. Muscle spasms is like muscle that stiffens abnormally and refuses to relax. Is a muscle, if you have ever had a muscle pull before, you know how badly painful it can be. You would almost find it difficult to even extend your legs. Now, imagine someone has equivalent of that kind of pain 24/7. There's no way that person will not have a chronic pain, but it's not a pain that is caused by an external injury. So you want to give a muscle relaxant in addition to whatever medication you want to give such a patient. So example of muscle relaxants that will be given for such purposes, ofenadrine. Ofenadrine is in the pharmacy. Usually it's combined as paracetamol and ofenadrine. So a very common one you find in the pharmacy is Ofesic. Please, tomorrow, go and look for what is Ofesic. Then carisoprodol is an example. Metocarbamol is also in the pharmacy. It's a wonderful muscle relaxant. In fact, if you take it, you just feel all your muscles getting soft and you want to sleep. It's not a sedative, but because it softens the muscles and makes the whole muscle, skeletal muscle in this case, very relaxed. Naturally, there's that tendency of wanting to sleep. Then clozazone is one of them, and the other one that is mentioned there. Then we already explained neuroleptics, which are drugs that would have a bit of antipsychotic properties in a bit to relieve pain. So on that note, we come to the end of analgesics. So what are some clinical considerations that you want to keep in mind when you give your patient analgesic? Not all analgesics can be given to all patients. So your analgesic should be tailored to a particular patient. What do I mean? I have a patient who had a cesarean section. Of course, I know I need paracetamol. Of course, I know I need diclofenac. Of course, I know I'll probably need pentazocine at least for the first 48 hours of surgery. But if my patient is a patient with known peptic ulcer, that will not be a good candidate for diclofenac. So I have to play around some other type of analgesic. That's what it means to tailor your medication to a patient's preference, no, to the patient's individual personality. Or if I have a patient who I know suffers from substance addiction, that will not be the patient I want to send home with 3 boxes of codeine. You understand? If I'll give you, maybe I'll give you 6 tablets or 2 tablets. Then if the pain is bad, come back in another week, I review you, I assess the severity of the pain, I give you a little more. I will not give you 30 tablets because I know you can go and take all the 30 tablets in a day. So analgesic should be tailored to the patient. Then you would also want to carry out a patient assessment. It's not all the painkillers you will use at a time. So there's something called pain scale, which we'll discuss in the next slide. You want to assess the intensity of the pain. Someone who has severe pain and says, this is the worst pain of my life. You can see this person is crying and jerking on the bed. Paracetamol has no place in that kind of situation. You're going for something strong, something high. You're going for opioids that are on the higher scale. Then the type of pain. If someone tells you, I did not get injured, I've just been having a shooting pain, or I've been having peppery sensations on both legs and I cannot sleep, and you know this patient is diabetic, that's not a patient you want to give opioids. You know this is likely an adjuvant analgesic because this is likely a neuropathic pain. Please remember what we discussed, nociceptive pain and neuropathic pain. So you know likely this is a neuropathic pain. Then you want to individualize the treatment plan. Want to consider some comorbidities. Comorbidity is plus, morbidity is sickness. What other sickness does my patient have? Then you also want to consider drug interaction. Is my patient taking some other drugs that the drugs can begin to interact among themselves? Then your patient preference. Does this patient have a particular flare or concern about the way some drugs act and things like that? That's just what it means for your analgesic to be patient-centered. Then in some situations, you may want to use multimodal analgesia. It just means you're using multiple modalities. So I'm using paracetamol, I'm using NSAIDs, then I'm using opioid based on the severity of the pain that I'm dealing with. Post-operative pains, like if somebody had a fracture and then you do a surgery, that is a very, very bad kind of pain. You want to go as high as you can go on the scale of analgesics. Then, of course, when you give painkillers again, especially if he's an inpatient, even if he's not an inpatient, if he's a patient who takes painkiller for a while, you want to do monitoring and follow up. For instance, if the person tells you my pain scale is 10 today, and then you do your review in 48 hours time, it says the pain is just like 2, then I don't need painkiller that is strong enough for 10. Again, I probably need something that will be able to take care of 2, so we'll bring it down. Then you want to also consider fixed dose combinations. You know, I explained fixed dose combinations to you, so you want to keep that in mind when you're prescribing drugs, when you're explaining, so that your patient will not say, I was told to take 2 tablets, so but the pain did not go. Maybe I can go and take 2 more. Keeping in mind that there is maximum dose that is possible with fixed dose combinations. Some drugs may still give you opportunity to go higher, but the other member of the drug, you cannot go higher than that. So you want to keep that in mind. Then, of course, you don't send patients home with anything. Any patient you will send home with any drug more than paracetamol. In fact, even if it's only paracetamol, you want to do adequate patient education. That will be keeping to prescription as recommended, not mixing it with drugs that are not recommended. If it's a drug that has a risk of causing ulcer, like all of those NSAIDs, you want to tell your patient, please eat ahead of time. And just other necessary things that you need to tell your patient. Doing this one, you are coming in and going out like this. Is it network or you are doing some other things? Doing, where are you? Your face is coming and going.
Sorry, ma, it's my phone.
Okay, tell the phone to be able. Okay. So now pain levels. This chart here is called pain scale. For every patient who presents with pain, ideally you should do something called pain assessment of pain levels. Because if the patient says I'm having headaches or says I'm having tummy pain and I've not assessed for the severity of the pain, and I then go and give something that would relieve mild pain for a pain that is severe, the patient will not get better. It's as good as I've not done anything. So on a scale of 0 to 10, 0 being no pain at all, 10 being the worst pain possible. I mean, after this one, I cannot have a pain worse than this. You then ask your patient that, how would you scale the pain? Between 0 and 10, 5 being the pain is somewhere in between. And most patients, at least even the uneducated person, will be able to give you a brief idea. So if the person tells you my pain is like 8, you know that is a very severe pain. If someone tells you the pain is like 2, okay, maybe like a mild pain. Or someone tells you it's 5, you know, maybe like a moderate pain. Then even if the person is not able to give you by numbers, you can also look at the facial expression. You have a 52-year-old man comes in limping and screaming or crying. You can see tears on his face. You don't even need to ask that type of person that what's the severity of your pain. The facial expression already tells you this is one of the worst possible pain that a 52-year-old man can experience, so much so that he's screaming and crying. So facial expression too also allows you to do a brief gauging or assessment of the severity of the pain. So now this one just explains it a little more. So someone who tells you my pain is 0, it means there's no pain. So that's the first class, and whether we call it a class or no class. Now, someone who says my pain is mild, or mild pain will be between the scale of 1 to 3. So mild pain could be that the pain is just annoying a bit, but it's not interfering with my daily activity. So I can still go to work. I can still do things that needs to be done. So number 1 will be that the pain is very mild, it's barely noticeable. So most of the time, I'm not really thinking about it. I just know once in a while it comes. So that would be, what would I use as an example of that now? Example of mild pain. Well, example of mild pain, just think about it. Maybe I'll get an example for subsequent one. Minor pain will be something that is annoying. So is annoying, but it may have occasional stronger twinges. So Once in a while, it just bothers me, but sometimes it really, really could be bad. Then it goes again. So it's coming and going, but to a large extent, I'm still able to carry on with life. That could be maybe the pain of headache. You know, you may have headache and still do lectures. You know, it's like a mild pain. We're still doing things, but it's annoying me. I wish my head is not aching. Then someone who has a pain scale of 3, is the pain is noticeable, is distracting, so much so that you can't really focus. But after a while, you can still tell yourself, okay, I have a headache. It will go maybe when I sleep, and you can still carry on and complete the lecture. So moderate pain will be a pain between 4 and 6. So such a pain will be considered to interfere significantly with activities of daily living. So while the person goes to work, the person limps to work. So he can go to work, but it's affecting it in some way or the other. While the person sleeps on the bed, the person is turning around with significant pain. So if someone gives a scale of 4, that's moderate. So it could be that if the person is deeply involved in an activity, they may not really notice it, they may ignore it for a while, but it is still distracting. Then pain that is a scale of 5 will be considered moderately strong pain. So it can be ignored for more than a few minutes, but with effort, you still can manage to work or participate in some social activities. So I am limping to work, I can still have a bit of fun. I know the pain is there, but I can still limp and show up at work because I put my heart to the fact that I must show up at work. Then moderately strong pain would interfere with normal daily activities. The person cannot even concentrate. So the severe class is disabling with inability to perform daily activities. So that will be those ones who come to the emergency. That will be someone who had an accident and was carried in by a friend. That will be someone who had severe pain in school and passed out and was rushed in. All those ones are classes of severe pain. Or someone who had a surgery. Someone who had a surgery is not doing any activities of daily living. He's not bathing, he's not doing anything, and he's just focused on healing. So a pain scale of 7 is a severe pain that dominates the person's senses. So essentially all that the person is thinking about is that pain. And it will significantly limit their ability to perform normal daily activities or maintain social relationships. And it may even interfere with their sleep. Then a pain scale of 8 is intense. Physical activity is severely limited. In fact, the person may not even be able to converse, may not be able to talk because you're focusing on that pain. Just like, don't leave me alone, I cannot talk now. Then a pain scale of 9 is excruciating. The person is definitely unable to have conversations, maybe crying out or screaming or moaning uncontrollable. That will be the kind of pain that a woman in labor experiences. That will not be the time you want to joke with any woman in labor. She's not in the mood for that. Then number 10 is unspeakable pain, the worst pain possible. It's a pain that you can't even move the body parts. So it's like the person just stays frozen. So the person may be bedridden. In fact, some pain could even take some people out of their senses. You just check out of your body so that the person can survive the severity of such pain. So very people would ever experience this level of pain. Anyway, thank God for that. So on that note, we come to the end of analgesics, so I can share the next slide. So we'll just pause a while for questions. We have questions. We have questions. Is it that we understand or we don't understand at all? Please say something. Do we have any question?
No question.
Does that mean you understand, or it was too complex for you to understand? It's okay. So maybe when we see in class, I'll send the videos tonight by God's grace. So please, what I will say is do well to watch the videos tonight so that if you have lectures, if you have questions tomorrow, we can address it in class. I'm hoping we can take 2 more. The 2 more we are taking, they're not complex. So let's go. So we are discussing nomenclature of drugs. Nomenclature just means drug naming. I think I mentioned it briefly in some of the classes we've had, but maybe not in details. So nomenclature would mean, or it implies assigning proper names to a particular compound so that the study of such a compound, the marketing of such a compound, or the use of such a compound may be systematic. So proprietary of drugs would be divided into 3. There's the chemical name of drugs, the nomenclature of drugs rather, there is the non-proprietary name and there is the proprietary name. So chemical name, simply chemical from the word chemical. It's a name that you give to a drug in accordance with the rules of chemical nomenclature. When you hear nomenclature, it just means naming, and is established by certain conventional bodies. Just the same way you have maybe bodies of MDCN, like is the Medical and Dental Council of Nigeria, that will be able to name various vocations of various segments of the medical field. So HIUPAC is the International Union of Pure and Applied Chemistry. So what they do is name chemical compounds. At the end of the day, drugs are chemical compounds. Just the same way, the same drugs, the same chemicals you used in your chemistry lab, you also add chemical name. HIUPAC also give names to drugs that are of chemical compound. Another group of body that also names drugs and gives them their chemical name is Chemical Abstract Services. So every drug, you name it paracetamol, you name it vitamin C, they have their own chemical name. So example of such a chemical name is this drug here, N4-hydroxyphenylacetamide. That is paracetamol. I'm sure you wonder, is this paracetamol? But imagine if this is the name you have to say every time you want to give a prescription to a patient. It's cumbersome, it's clumsy, many patients will not even be able to say that. So it is useful for only the chemists, the scientists, or the technical personnel. So you will not bring that to the field if you have to do your medical practice. But of course, you know at the back of your mind that, okay, this is the chemical name of such a drug. So it provides the precise arrangement of the atoms and the atomic groups of such a compound. Simple organic chemistry or simple chemistry. By the time you see this, those who are chemists will be able to break it down and tell you this is the way it is arranged to then form this compound. So that is essentially what chemical name means when we discuss drug nomenclature. Now, the other nomenclature for all drugs is non-proprietary name. So non-proprietary names are short names that are given to a drug that is not subject to proprietary rights. What that means is the name is, how do I explain? There's that complex name that we just said that the average person will not be able to say. Then the same group sits again and then gives a simple name that is easy to speak and easy to spell, such that it will replace the long chemical names of such drugs. So it is not owned by any pharmaceutical company. The same way vitamin C is not owned by any pharmaceutical company. But if Temi decides to make her own vitamin C, she can call it Temi C. That will then be the proprietary name. That is her own company name. But paracetamol is the generic name. Generic, like from the word general. So across board, everybody knows it is paracetamol. So that is what non-proprietary name is. Even though the chemical name for paracetamol is this mouthful that is N4-hydroxyphenylacetamide. The generic name, which is the non-proprietary name, which is not the name owned by any pharmaceutical company, is paracetamol. So that's the second nomenclature of drugs. So this then leads us to proprietary name. The same way I said, Temi can make her own vitamin C and call it Temi C. So proprietary names are owned by brands, by trademarks, or by registered pharmaceutical companies. So they could be a brand name, they could be a trade name, they could be a registered name. So it's given to the drug, to such a drug by the pharmaceutical firm which sells the drug. So if we all make vitamin C, Temi's own can be Temi C. Mrs. Oke's own can be Oke C, Abi Esther C. Mine could be Soje C, and so on and so forth. But at the end of the day, the generic name inside all of our vitamin C drugs is still vitamin C. It's just that our proprietary names are different. So a single drug may be sold under many proprietary names by different firms. If you go to the pharmacy or any average chemist, you see several brands of paracetamol. At the end of the day, the same chemical compound should be inside because they should have the same generic name, the same generic compound. It's just the proprietary name, in this case, the company name or the pharmaceutical name that differs. So even a single pharmaceutical firm may also have different proprietary names for a single drug that has different formulations. So they can tell you one is extended release. They can tell you one is extra strength. You've seen paracetamol that they'll say is extra strength, prolonged release. They will tell you is chewable tablets. They will tell you is effervescent because it releases some gas. Or they will tell you is dissolvable inside water. At the end of the day, it's still paracetamol. So they may now give different proprietary names for each of those different formulations. So you as the clinicians would usually prescribe drugs by their proprietary names. If you choose to use generic name is also fine. But if you write that Panadol, TDS, you have just prescribed the proprietary name. Now, the challenge is that if they don't have Panadol, the hope is that whoever goes looking for such a drug should know that Panadol is also paracetamol and should be able to go say, okay, give me paracetamol if you don't have Panadol. The two of them are the same. But most importantly, you as the medic must know that the difference between all of those names and the similarity among all of those names. So classical example then would be paracetamol. The chemical name is N4-hydroxyphenylacetamide. The non-proprietary name is, there's the approved name, British approved name that is paracetamol. There's the United States adopted name that is acetaminophen. Both of them are the same. There's the official name of acetaminophen. All of those ones are non-proprietary name. Then you now have the proprietary name, which is pharmaceutical names, Panadol, Calpol, Adol, and so on and so forth. So on that note, we also come to the end of this second presentation. Now, do we have questions? Waiting for questions, or I'm waiting for it to sink in, either of the two. John, ask your question. Doi, is it your ceiling that is attending the lecture? Oh yeah, John, you are muted. Unmute yourself so we can hear you.
I don't have question now, ma.
Okay. Blessing, ask your. I'm waiting for Blessing to ask a question. Okay, so what does proprietary name mean then? Let's see your beautiful face. So it's your hair you are showing us. What does proprietary name mean? Okay, so if we have N-phenyl something something acetamide, and we have paracetamol, and we have M&B Panadol, which of these is the proprietary name? Unmute your what did you say? Unmute.
Panadol,
Okay, so
and paracetamol.
no, the Panadol is the proprietary name. The paracetamol is non-proprietary name. Nobody has a sole ownership to paracetamol. It's across board. So then if we say we have ascorbic acid, and then we have vitamin C, and then we have 2-yl-C, which of these will be the non-proprietary drug?
Please come again.
If we have ascorbic acid and we have vitamin C, both of them are the same. Ascorbic acid, vitamin C is the same. And when we have 2-yl-C, which of these will be the non-proprietary name?
The vitamin C, man.
The vitamin C is non-proprietary. It's the same across board. Nobody has the sole ownership to it. But if I make my own and I name it 2-yl-C, that is a proprietary name because it's my company's name. Ascorbic acid may be the chemical name, or it may also still be the non-proprietary name. Do we understand this a little so I can go ahead?
Yes, ma'am.
This thing is not hard now. Mrs. Okay, you're welcome to church today. You are muted, though we cannot hear you.
I've been trying to join because of the network.
And no, Allah, you're welcome. How was church?
Yes. Thank God.
No. So let's go ahead. So antacid is just a few slides. We'll just discuss it so we can call it a day. So what are antacids? So they are substances that will neutralize stomach acidity. So medically is used to relieve heartburn, to relieve indigestion or a tummy that is upset. And sometimes it may be used for constipation or diarrhea. It will be used for constipation or diarrhea because we would employ the side effects of the antacid to either induce diarrhea in a constipated patient or to induce constipation in a patient with diarrhea. So those are the common uses. So what are the constituents? If you pick up a classical antacid, what are the contents that you will find inside? So some contents you will find inside are aluminum, find calcium, you will find magnesium. Mrs. Okay, mute your audio. You would find sodium bicarb, and this will act as bases. Bases are alkaline substance or called alkalis, and it will counteract stomach acid. Counteract is like negate or neutralize stomach acid, such that the pH within that person's stomach will be more neutral. What is a neutral pH? Tell me, what's a neutral pH? It's chemistry, whether we'll call your chemistry teacher today.
5 to 6.
Eh? What is not? If you say this pH is neutral, what is the number? Okay, any pH less than 7 is considered as, yes, thank you. I knew you would tell me, thank you very much. Any pH less than 7 is considered acidic. 7 is considered neutral. Greater than 7 is considered alkaline. Are we together? This is chemistry. This is not medicine. So the aim of antacid is to counteract the stomach acid, which will have a pH less than 7, and bring it somewhere close to 7. So somewhere close to the neutral point. So what do we use it for? We have said it a little. Indigestion is also used for heartburn or acid reflux. A patient who has heartburn will tell you that my chest is peppery. So the upper tummy and the middle of the chest is peppery. And some persons who know the terms would probably tell you that they have heartburn. So medically is also called gastroesophageal reflux disease, GERD. Gastro is stomach. Esophageal is esophagus. Reflux is something is going back. So the stomach acid is going back from the stomach into the esophagus. So it's washing the esophagus. Esophagus is the gullet. We know we have done gastrointestinal system. I won't go back. So the same acid that should help for food digestion, hydrochloric acid and some other ones, can then go back into the esophagus and wash the mucosa of the esophagus. So it's peppery. Okay, so it's also used to relieve gastritis. Gastritis is not ulcer. This one is just inflammation of the stomach lining. So if the stomach lining is inflamed, like you have a wound on your skin, and you know that naturally your stomach will produce acid. So if the stomach acid is inflamed and your stomach is producing acid naturally, it's washing an inflamed stomach lining. So the pain is worse, the healing is delayed. So in such a patient, you want to give antacid. Some bacteria can cause gastritis, just the same way you can have intestinal infection and be having watery stool. They can also cause gastritis and cause wounds within the stomach lining. So such a patient would also be given antacid so that we can neutralize the acidity such that healing can take place. So now antacids generally are sold as over-the-counter. Over-the-counter drugs are drugs you can just go and purchase from the chemist store. You don't need prescription. You can just call it by word of mouth for them and they'll give it to you. Paracetamol is one of such. Antacids are one of such. Vitamin C is one of such. So those are over-the-counter drugs. So antacids are available as over-the-counter drugs and they are taken by mouth to quickly relieve occasional outburn and major symptoms of gastroesophageal reflux disease and indigestion. So treatment with antacid alone is symptomatic and is only justified for minor symptoms. What do I mean by symptomatic? There are two ways commonly that you will treat any disease. Either you're treating it symptomatically or you're treating it curatively. If I have malaria and I'm taking paracetamol so that I would not have a headache and I will not have a fever, I am symptomatically managing that malaria. I am not planning to cure it because paracetamol does not cure malaria. But if I do decide to go and take anti-malaria, then I am doing something curative. So when someone decides to go and get antacid over the counter to drink at home, is a symptomatic management just to relieve those minor symptoms of heartburn. The definitive management will then be to get diagnosed what is giving me these symptoms, and then we get a cure. So alternative uses for antacid will include constipation. I told you that, diarrhea, hyperphosphatemia, and urinary alkalinization. Those are alternative uses that are not routine uses. Okay, so non-particulate antacids. Non-particulate means it doesn't have sediment. Those ones are usually like they are clear, like clear fluid. If you've ever held any antacid, you'll see it's whitish. And some antacids, when you put them down for a while, it settles, it separates. So you have the fluid on top and you have the particulate matter at the base. So some examples of non-particulate matter non-particulate antacids are sodium citrate, magnesium trisilicate. So what they will do is to increase gastric pH. When gastric pH is increased, it is higher than 7. So you are having pH of 8 and above. So it will increase gastric pH with little or no effect on the gastric volume. Little or no effect on the gastric volume because they are clear fluids that can neutralize and then be absorbed. They would not constitute to the gastric volume. So they may have some limited uses in preoperative procedures. A patient that has been fasting for 24 hours because the patient is going for a surgery and then starts to complain that my tummy is biting me, and you're thinking, okay, maybe because the stomach is empty, the gastric juice is washing the stomach, and you're thinking, what can we give this person? Because we know he or she cannot eat and we're going for surgery, and we don't want he or she to come out with ulcer at the end of the surgery. So you can give a non-particulate antacid in such a situation. 5 mils, 10 mils of it will not do much. It will not even increase the gastric content, so much so that the patient will not vomit. So sodium citrate could be given within 1 hour of surgery to be most effective. So you could give it like 1 hour before surgery for someone who is not planning to have a surgery within the stomach. You understand? Any other types of surgery, wants to do CS, wants to do a bone surgery, even though we say don't eat to go to surgery, and the person is having pains and you're concerned, or this is a patient with peptic ulcer and you know you don't want to keep them fasting for long, you can give them a non-particulate antacid before surgery. Okay, so how do antacids work? So as we said earlier, we said they're over-the-counter medications that will help to neutralize stomach acid. So they work differently from other acid reducers. There are 2 other acid reducers that we'll discuss. H2 receptor blockers, example is cimetidine, everybody knows cimetidine. And proton pump inhibitors, example is omeprazole, everybody knows that. That is another presentation when we discuss medications for ulcer. So now those drugs will work by reducing or preventing the secretion of stomach acid. That is how those 2 classes work. But what antacid will do is that it will neutralize the already produced stomach acid. H2 receptor inhibitor, H2 receptor blocker and proton pump inhibitor will not even allow the stomach to secrete acid, or it will reduce it, frankly. Antacid is not working at the level of secretion. It is just diluting or neutralizing the acid that has already been secreted. So antacids can be used to treat symptoms of excess stomach acid, such as acid reflux, and such symptoms could include regurgitation, like you lie down and you feel that acidic something coming back to your throat that is peppery, that is bitter, or that bitter taste that comes from someone who has a reflux, not the bitter taste of malaria. You know that thing flows down your throat and it's very bitter. Or someone who has a persistent dry cough from gastroesophageal reflux disease. When they lie down and they have that reflux, some of those stomach acid will irritate the pharynx and the larynx, and they can have laryngitis, pharyngitis, and then start to have dry cough just from irritation. Or maybe they have pain when lying down, pain many times heartburn, because that's when the stomach acid can be able to flow better because of gravity. Or someone who now has very bad gastritis, esophagitis, as the case may be, and they have trouble swallowing because the acid has burnt the mucosa of the esophagus. So such persons, we want to give antacids to them. So we have 3 major types of antacids. We have liquids, common liquids that we know. Common liquids, somebody tell me common liquids. John, example of common liquid antacid.
Syrup, ma.
And tell me the name now.
This thing, alpha. I'm coming, ma.
Anybody can help him.
Gospel.
You said?
Gospel.
Gascol, yes. Gascol is an example of a liquid antacid. Thank you very much. Then there are some types that are chewable, or that they are like, you know, the way you can chew gum. They are gummy, they are tablets like. So there are those types. And there are those that are tablets that you just place in your mouth that it will dissolve in your mouth. Some chewable ones that are not like gum could be what? Tell me. Example of antacid that is chewable, that is not like gum. It's very common.
Jealousy.
Jealousy. So that's big tablets now that people used to fake and say they have stomach pain in primary school. Everybody should know it now. That tastes like peppermint like this.
Anacid.
Danacid, yes. Danacid, jealousy, all of them like that. So those are examples. Okay, so it could be liquid, it could be chewable gummy, or tablet. It could be tablets that dissolves in water to drink. So there are some you just put in water, dissolves, and you swallow it. Okay, so what are some precautions you want to keep in mind when you're prescribing antacids for your patients? Generally, they are safe for most people. It's just that some people with certain medical conditions, especially because, again, you know, it's over-the-counter drugs now. So picture that you have a pharmacy in the future and someone is coming all the time to come and be buying antacids. So it will be your call to say, come, go back and discuss with your doctor first. Or by then, say you may have the skills to now examine the person. Because someone who has heart failure may be on sodium restriction. Some persons are placed on sodium restriction. Those will not be good candidates to keep taking antacid. So some patients too would also want to, because like aluminum hydroxide, magnesium carbonate, especially for someone who has renal impairment, that you know the excretion of such substances may not be optimal. You want to be sure that it's been correlated with the managing physician before they decide to buy it over the counter, especially for repeated use. But in all honesty, most people can safely take antacid with little or no side effects, except for those ones I've mentioned to you. So people with kidney failure may develop a buildup of aluminum after using antacid. So this can lead to aluminum toxicity. People with kidney failure, again, also tend to have problems with electrolyte imbalance. If you see their AUCR, you would always see all of those electrolytes, they are very scattered. So that's the person that is now taking extra sodium. Before you know, sodium has jumped up. So all antacid contain electrolytes. Some will contain sodium, some will contain potassium. They just contain at least one electrolyte. So this could make their electrolyte imbalance. It could make it worse in patients with kidney failures. Now, children typically will not develop symptoms of excess stomach acid. So ulcer is rare, very rare in children. If you do have it in a child, there's a cause. It's not for a symptomatic relief. It's to find the cause and cure the cause. So if you find a child who has symptoms that is looking like excess stomach acid or symptoms of ulcer, it's not just that the person should just be drinking antacid. Such a patient should ideally be checked up, should be worked up for a proper diagnosis, because it's not so common in children. So what are some side effects of antacid? So we said side effects already, they are rare, generally because it's safe, kind of. But they can cause constipation, or they can have laxative diarrhea-like effects. And some people could even have allergic reactions, allergic to aluminum, just the contents that is inside it. And some could become gassy, so they can be messing a lot, or they can be passing flatulence a lot. Flatulence means to fart, to mess. So they could be gassy and be releasing a lot of flatulence. That doesn't sound like a serious side effect anyway. So antacid may also increase the risk of developing sensitivities to certain foods.
What of too much belching? If someone is belching too much.
No, it is even used to release belching. What it can cause, it can cause more acid down. You understand? So the person can end up releasing more gas, not that it would bring it up. You understand? Because by the time you neutralize the old stomach acid, you would shift around some normal bacteria within the stomach. You will shift some things around. In fact, chronic treatment of ulcer increases the chances of some patients developing or being prone to stomach infection easily, because stomach acid does its work of trying to help you kill some bacteria initially. So when you have now neutralized all of them, the stomach is exposed. There's no acid that is protecting anything. So bacteria will shift around and may be able to produce more gas. So now formulations containing magnesium salts may cause diarrhea. We already said that. So that's why you can use it. You can employ the side effect in a patient who is constipated to induce diarrhea. Then those that are containing calcium or aluminum may cause constipation. So if you have a patient who is having diarrhea, you can also employ this side effects to induce constipation. but rarely will you have a long-term effect from use of calcium carbonate that can cause kidney stone. Is not impossible, but is very rare, because seldomly will you have someone using antacid chronically on a daily basis for more than 2 weeks, except the person is abusing the antacid because the taste is good. Okay, long-term use of antacid containing aluminum may increase the risk of developing osteoporosis. Osteoporosis is the bone beginning to thin out. So like, if you can remember that time we discussed musculoskeletal system, that we were discussing cancellous bone and compact bone, and we told you that osteoporosis looks like that, those punched out holes that you will see in a bone that is weak, because aluminum will then go and displace calcium from the bone. So the chances of such a person developing osteoporosis would be increased. Now, if someone now decides to misuse because it tastes so good and the person finishes a whole bottle, it's not impossible. All sorts of abnormalities could be seen in the medical field. So most side effects that you observe is not from the drug itself, is that the person did not take them as directed. So if your patient takes too much or take them for longer than is directed, they can get an overdose of calcium. Too much calcium will cause symptoms like nausea, vomiting, mental status change. So the patient could be confused, could be dizzy, could be irritable, could be restless, could be rational. Or frankly, the person may develop kidney stones. That's why they say too much of everything is bad. Even if it's a good thing, it could be bad. So excess calcium can also lead to alkalosis. Alkalosis now is the alkalinization that you're hoping to get in the stomach, almost like you're trying to neutralize the stomach acid. Some of those electrolytes now shift into the blood. If you can remember intracellular and extracellular fluid, there's only some electrolytes you'll find in the intracellular and you'll not find in extracellular. So some of them will now shift into the blood and then begin to induce an alkaline state in an acidic state. So if you ever check anybody's kidney function, you will find pH there. pH is also one of those things that is expected. If someone now has an alkalosis, you will find that the pH is higher than expected. So that's a possible side effect that can happen in someone who has excess calcium. So in this condition, the patient's body does not make enough acid to function properly. Okay, so, and if your patient has taken antacid according to direction and they don't feel relief, you want to refer them to the managing physician, because peptic ulcer, if it's just excess stomach acid, generally is easy to treat without much hassle. Okay, so what are the mechanisms of action? When an excess amount of acid is produced in the stomach, the natural mucous barrier that protects the lining of the stomach can be degraded. So this will lead to pain and irritation. What do I mean? If you look at the mouth, there's the mucosal lining, then there's the saliva that protects it. Now, when there's excess acid that is being produced, I'm just trying to use the mouth as an analogy of the stomach. The natural mucous barrier that will protect that lining will be degraded. So the acid is washing out the natural mucus that should protect. So if that natural mucus is degraded, the lining is exposed to acid just washing on it. So that can even further chop out or degrade the lining, the mucosal lining. Then of course, what would the patient be having? You have pain, you have irritation. So, and this would also now increase the potential for development of acid reflux. I mean, there's now plenty acid, there's no mucus that is natural, that is diluting it, so to say. So some of it will reflux back into the esophagus. So this one can also cause pain and damage to the esophagus. So now the antacids that contain alkaline ions. You know, opposite of acid is alkaline ions. They will chemically neutralize the stomach acid, and in neutralizing those stomach acid, they will reduce damage to the stomach lining, the esophagus, and of course, relieve pain. So some antacid would also inhibit pepsin. And when I don't know who taught you digestive enzymes, pepsin was one of such. Pepsin particularly digests proteinous substances. So it can also inhibit pepsin, which is an enzyme that can damage the esophagus in acid reflux. So antacids do not directly inhibit acid secretion. I've said that in several, be sure it will come out in MCQ. It doesn't directly inhibit acid secretion. So they are distinct from H2 receptors like cimetidine and proton pump inhibitors like omeprazole. Again, antacids do not also kill bacteria, Helicobacter pylori, which is the bacteria that causes most gastric ulcers. That's why if you would see us treat gastric ulcers, we'll write omeprazole, we'll write antacid, we would also write an antibiotics to take care of the bacteria. So while you're using an antibiotics to take care of the bacteria, omeprazole is reducing the production or even inhibiting the production of stomach acid. Then the antacid is neutralizing any bit of acid that even gets produced. So you have, they call it triple regimen. So there's the antibiotics knocking out the Helicobacter pylori, which is the bacteria. There's the proton pump inhibitor like omeprazole that is inhibiting the production of stomach acid. Then there is the antacid that is neutralizing any stomach acid that does get produced. So what are some formulations? So antacids may be formulated with other active ingredients such as simeticone. Simeticone, you will commonly find it in Gaviscon. You find it in Gascol. So what it does is to help to control gas or alginic acid to act as a physical barrier to the acid. Is incorporated with simeticone for two reasons, because some of these stomach antacids themselves, because they will shift things around, can make the patient prone to producing more gas. So simeticone can be used to just dampen that side effect. So it's not the process of now we are taking antacid, we're trying to neutralize stomach acid, but then we're having the side effect of being gassy and passing flatulence when we do not want to. So that's why it's incorporated with some of those variants of antacid. So there's the liquid one. Common one is milk of magnesia. That is the ancient one that used to be in primary schools or secondary schools that comes in 2.5 liters, milk of magnesium. Then there's the magnesium aluminum combinations. It's called something trisilicate. But you would, that is trying to say a common drug like that. That's mismag. That is mismag. Magnesium trisilicate. That's mismag. Everybody knows mismag. It comes in smaller bottles. It usually will separate. When you put it down, water floats on top and the liquid comes down. It's more recent. Milk of magnesia is not routinely used again. You will still find mismag in some pharmacy. I think To Yield still makes mismag. But because, you know, as evolution comes now, as science begins to refine, some of those drugs, they start making newer brands that has less side effect and is more potent. So tablets, we have chewable tablets like Antacids, like Gelucy. So common salts that are available in tablet forms include those of calcium, magnesium, aluminum hydroxide. This just means these are the electrolytes that are commonly inside them. Then there are some tablets that are effervescent. You put them in water, it does shh, and you see gas coming up. So it looks like to just release some gas, looks interesting, then it dissolves and you can drink it. So effervescent tablets are tablets which are designed to dissolve in water and then release carbon dioxide. So carbon dioxide is that gas that comes out and makes that shh sound, okay? So here we have examples of common antacids. Which one do you know here? Tell me. This picture, which of the drugs do you know here? There's a common one that's inside the pharmacy here.
Gaviscon.
Gaviscon, yeah. Gaviscon is in the pharmacy. So that's a common one. Here, well, I don't know if you know anyone here, but our ancient of this Gelucy is here. Before it came in a gigantic cup, it used to be in those small boxes. So our Gelucy is there. Then this is also a variant of Gelucy or Antacids, all those tablets that are chewable. Some colors and flavors are added just to make it more palatable. And then most people will know Gascol. Just these are the variants. Why I put up these pictures is you would, if they say list possible antacid, you can still be listing hundreds, thousands, because of that thing I explained, proprietary brand. So all of us here can decide to say we want to make our own brand of antacid and give it different name. At the end of the day, your interest now is what is the chemical composition of what is inside. Will it do what it's expected to do? All right. And on that note, we come to the end of this presentation. I think it's been a fruitful one. We now take 1 or 2 questions so that we can call it a day. Do we have questions?
Yes, ma'am. Can we use polygel to treat ulcer too?
Yes, but it cannot be used alone. It will be used in addition to something else. So in addition to omeprazole, which is a proton pump inhibitor, in addition to an antibiotics that would help take out the Helicobacter pylori, the bacteria that causes ulcer.
Okay. Okay.
Okay, so in the absence of more questions, thank you for being here and thank you for putting on the video. At least I'm not the only one on the table today. So we'll see you next week. We'll see tomorrow anyway. If you have any question when I send the video, just look at it, jot your questions. We'll discuss it in class tomorrow. Enjoy the rest of your evening. My regards to your family.
Thank you, ma. Ma, please, I have something to tell you.